Hello, everybody. I welcome you to this performance health webinar, which is a bit of an experiment. So there's a much smaller group of you with us today. You're the special group that warranted these extra webinars, and thank you to the team who came up with the topic. I only hope that I can meet your expectations. And the intention this time is that rather than me talking and then stopping for questions at the end, we really welcome you to put questions in as we're going along. And Rachel here is going to try and be both my model and also read the questions as we're going along. And I will try and let's try and make this into a bit more of a conversation, possibly around the whole of the UK. I think everybody's from the UK. So the topic that was chosen was to look at the role of splinting in flexor tendon repair. So I've got a very short presentation, and then we can explore together the different types of splints that we might need to use through the duration of the flexor tendon process. Now, I'm really going to concentrate on the splinting side of this rather than different regimes and why you might use one regime over another. That's a whole different conversation. And so let's get going. Let's start with the presentation and off we go. So just to introduce everybody properly, this is Rachel, and she is one of the lovely reps from Performance Health, and she's become my absolute trusted webinar partner. Now we're turning into a good team, and I'm Nicola Goldsmith, and I'm clinical ambassador for Performance Health. And so off we go. We're going to look through this hour at the role of splinting in primary tendons, tendon repairs, but then also really concentrate more on what happens when things go wrong or don't quite come as you want them to in terms of the rehab process. So we're going to look at the complications and the role, again, the concentration on the role of the splint. So what is the role of rehabilitation in flexor tendons? So summing this up on one slide, well, that was a little bit of a challenge, as you can imagine. So we've got to protect the repair, hence the splint. We need to prevent tethering, hence the splint needs to allow, of course, some movement as well as promoting the protection. We want to try and get that movement so we get intrinsic rather than extrinsic healing, which we know is going to lead to a smoother tendon shape, and it's less likely to get stuck in the tunnels, and it will be a stronger repair. And of course, then that will reduce our complications, whether that be with the wound, with edema, with the scar, with contractures, and we're just going to explore some of those. So when we want to splint healing flexor tendons, we are really looking at the flexor hood, of course. Now, again, there are multiple regimes. We've got the traditional back slap, which comes 2/3 of forearm to just to the tip, past the tips of the fingers. And then, of course, we've got the newer versions with the Manchester short splint. Again, not here to discuss regimes, but let's just look at the physical making of a flexor hood. And what makes a good flexor hood? Well, obviously, one that can last for the 6 to 8 weeks that you need it without causing any pressure or any problems on the skin. It's got to do all sorts of other things. So you need to think about the different angles that you want with your particular patient for your particular regime. So what angle is your wrist at? What angle are your MCPs at? What angles are your finger joints at? When you come to measuring it, this is one of the very few cases you can't put that hand flat on the table and draw around it, of course, because you risk rupturing the tendon. So for once, this is where you'll actually take your measurements on the contralateral hand, and we'll look at that in a second. Of course, initially when you make the splint, there'll be dressings on. So you need to make your splint with the knowledge that it's going to have to get a little bit smaller. So when you first make it, it's going to have to contour over dressings, and then as the dressings come away, and that's the joy of thermoplastics, is that we can just reheat them and remold them. We need to be really sure that we have neutral wrist alignment. So I remember having, when I was many years ago and seeing multiple flexor tendons, particularly every Monday morning, And you could tell the ones where the senior surgeon had done the repairs of the flexors, they'd left the operating theatre, they'd left the junior doctors to put the back slab on, and they got a little bit carried away. And they would really go far too far in terms of flexing the wrist, but also what tends to sometimes happen is that ulnar deviation comes in on the wrist. So we want to make sure we've got that neutral alignment. Then we've got to think about the bony prominences over the back of the hand. So we really predominantly with the flexor hood talking the ulnar styloid and the MCP joints. We want to make sure that the back of the splint really matches the shape of the back of the hand, which of course is very slightly rounded. In order to promote good flexion, you need to really make sure that you do have that lovely gentle metacarpal arch. Otherwise, if we're too flat, it inhibits our movement, or even if you're too bunched up, it also inhibits your movement. So we want to get a really nice arch shape here, but it's flat over the back of the fingers. So we want to have the component part over the back of the fingers flat, but with some edges. You also want to probably make it in mid-prosupination so that your patient is comfortable putting their hand down onto the table, but also comfortable lying with it, maybe rather than in supination, a little bit more pronated in bed. So I find that if you make it mid-range, then at least you're in a central position to allow some rotation in both directions of the forearm. And I would also suggest we want to make it just slightly longer than the tips of the fingers. Oh, yeah, you will have noticed this is not a fashion statement. This is my lovely silver splint, which is supporting my finger after my mucus cyst was removed and remained very painful and slightly malaligned. Then we also need to think about fixation. So what I would normally do in the first few weeks of a flexor is I would actually bandage the splint on, because you don't want to make it too easy for somebody to put it on and off. Then you can replace the bandage with some straps, and so that people can, when you start adding in wrist movements, then it's easier to manage. So we're going to have a look at making a flexor hood in a minute, but let's think about what happens when you 6-8 weeks down the line and you take those splints off and you have a look. And of course, there are a couple of things that can commonly happen. If we think about the proximal zone, so particularly zone 5 injuries, spaghetti wrist, multiple structures all repairing, lots of potential for tethering to other structures, we may well get a contracture, so that if we might even have isolated extension of the fingers or of the wrist, but when you start putting them together, it all starts to really pull. So we might need to make a splint that actually puts a really good long, full stretch through the whole tendon muscle unit. So we'll have a quick look at a splint for that. And then, even more commonly, with our more distal zones, is to end up with a flexion contracture of some sort of a PIP joint, which unfortunately is a common. All complications are rare, but it's a common complication of that. So we'll look at all the different ways that we can achieve our low load prolonged stretch to get through that PIP joint to try and extend it out. So as I said, we will look when you're going to make your full splint for proximal zone tethering, then you're going to look at what's happening at the elbow, look at what's happening at the wrist. Elbow only because if somebody's been sitting protected for so long, and they might sometimes feel a bit tight coming into full extension, and that is going to inhibit how they recruit their flexors. So we also want to have a look at isolated wrist, isolated extension, everything together, and then it'll give us the idea of what to do splint-wise. Little bit more decision making when it comes to those distal zones. If you've got a PIP joint contracture, how are you going to decide from all the different types of splints you can make? So just an idea, the modified Weeks test, written donkeys years ago, I think it was in the 1980s. This is a measure the joint at the beginning of your session. Do all your normal modalities, whether it be heat, mobilizations, passive stretches, active isolated movements, combined movements, remeasure. If there's only a tiny bit of change of the joint's ability to move actively and actively, sorry, in isolation and combined, this is what we would talk about as a joint that is much stiffer. It probably has a harder end feel if you get to, can I borrow you? Here we go. Now, this is what my splint allows me to do now, is I can actually put a pinch through. So if I actually measuring this joint, I'm looking to see what does it feel like if I do a PA or an AP on this joint. This is when I'm going to feel that harder end feel. So this is how I decide, okay, this is going to be a joint that's going to be slower, thank you, to actually recover. And if it's got a harder end feel, then you're probably going to want to do a volar static splint that you can serially change, or a plaster of Paris serial splint, which is worn 24/7. If it's got really good change, so at the beginning of your appointment, at the end of your appointment, there's really good change, you'll probably find you've got a soft end feel when you're doing that mobilization, then you're more likely to want to use a dynamic splint in order that you can, so that the splint can adjust to that changing range through the period of time that it's being worn. Or, in fact, a neoprene finger tube. Now, we definitely don't have time today to do neoprene, but that maybe is a topic for another webinar. And then you've got somewhere in the middle, so moderate change. Then you're going to, again, you could do a volar static splint, or you could do a serial static progressive splint, which to all intents and purposes looks like a dynamic splint. It's just the traction that's different. Okay, so we're now going to run through the making of a whole gamut of those splints. I'm going to put the computer away, so sorry, you have to put up with looking at the two of us now. And so let's just, I'm putting that away so I'm not distracted by it. And we're going to look at Rachel's hand here. So assuming Rachel's just had a flexor tendon repair. So we've got bandaging, doesn't matter at the moment whether it's a zone 5 or up into the zone 2, 1, it doesn't matter. But this is her affected hand. What I would probably do is leave this nice and elevated, out of the way, comfortable. And I would use her other hand, and I would probably take plinth roll, so slightly larger than normal paper towel. And then I'm going to drape it over the dorsal aspect of the hand. And you can see I've actually did this earlier. So I had pre-prepared this. But I would be cutting this to shape, obviously, without her watch on. So I know that I've got 50% of the contour of her forearm, that I'm going to put a nice little dog ear in at the MCP level, that the hood bit is going to be such that it's wider than the fingers to give me a little edge, which will make it much more stable. And I want it to end just longer than that middle finger, so that the middle finger is protected if it were caught and you catch it on something, you've got something there to protect you. So this I would then transfer onto my splinting material. Next question, which splinting material? So you have a choice. If it was me, I would use probably a 1.6 material. This person's got to wear it 24/7 for weeks. The lighter you can make it, the better. It's got enough contour in it that it's going to be nice and rigid and strong. So I made one earlier, and I've made this one out of Polyflex. So it was really moldable. So when it sits over the back of Rachel's hand, it was really moldable. And I don't know if you can see, if I just twist you this way. Yeah. I mean, it's even, you can see there, I think, the contours, you can really see that it's just picked up every bit of contour. Now, Polyflex 2, which is what this is a little bit more tricky to work with, particularly in a big splint, because it is quite floppy. So if you feel confident and comfortable, then that's fine. If you feel less so, then I would make it out of easy form. So I've pre-cut, so this exactly matches the pattern that I've made. So I'm just going to put that into the splint pan. And okay, so Just going to let that heat up. Now, I would probably remember that your patient's got dressings on. One of the things you can't do is this unless you're really careful, because of course what we don't want is anything pushing the fingers backwards. But otherwise, I would just put a very wide piece of tubing grip over, and you can always, you don't have to take it back off. You can just slit it with nice bandage scissors, and it comes away and actually forms a really nice lining. So here we are with Rachel. I'm actually going to make it with the wrist very slightly extended, so not far off neutral, slightly extended, fingers in this sort of position, and I'm going to explain to her how I want it to be, the position I want it to be, and then the most important thing when you're splinting, always say to your patient, please don't try and help me.
I promise.
It's really tempting, but please try not to help me. Right, okay. Let's get the splitting material out. Okay, so here's easy form. Now, it's the distal end that really matters, how long it is. So I'm just going to feel for her middle finger under here. I can't see it, but I can feel it. So I know I've placed this where I want it to, and get the MCPs in. And I'm going to put little dog ears in to make my shape. Now, remember, when your fingers are flexed, they adduct, they come together. When your fingers are extended, they abduct. So what I don't want to do is this, which is tempting to do, is to pull all the fingers together. So, but I actually want to allow the natural spread of the fingers, which you can actually see on the camera. I can't see, I'm doing that all by feel. So I can see that, but of course what I'm not going to do with a actual flexor tendon is push her back into there. But I'm just going to have a feel to make sure that there is enough length. And again, it's just longer. So we're going to imagine that this is a patient very early on in their rehab. Again, I'm just making sure I've made this in that mid-prosupination position. And we're going to just bandage it in place. More bandage. Okay, and then it's got one of those truly scary little to hook it. You have two, but I don't know where the other one is gone. Anyway, one's enough, that's holding it there. So here we have our flexor hood. It's already going off because it's 1.6 material. It's actually already nice and firm up this end. I can still feel it's quite warm down here. So if Rachel wanted to put her hand back down onto the table in order to do her exercises, it should remain comfortable on the forearm, which is really what we want. And you can see here, if I turn you that way, no, I'll just turn you that way so that people can see your fingers a bit better. So you can see I've got an edge on each side, just a lip on both sides here. And that just gives the stability, and it's going to stop this moving around. Now it's moving around quite a lot at the moment, just because it's still warm. But now if you were to make a fist for me, that's brilliant, and open out. There's plenty of room for those fingers to abduct. It also stops the fingers getting really sweaty in between one and the other. This is nothing worse than feeling those fingers all bunched in together and not very nice. So there we have our flexor hood. So that's nice and easy. Comfy? Yeah, very. All right, super. Right, so let's, why don't I ask you to do that for me? Oh, very obliging patient. Okay, right, there we are. And here we have our flexor hood. So easy form, 1.6. Of course, if you feel less confident with splinting materials, just go one size thicker. We'll give you just a little bit longer to work with it. So if you were to go to the 2.4, but this is just so beautifully light. It weighs nothing,
No,
which
it's
is
lovely.
just really lovely. Right, here we go. Let's put that one away. We can discard those somewhere. Brilliant. Let's go messy.
So we've just had a quick message coming through. So do you keep the bandage slightly looser in the palm to avoid flexing against resistance?
Yes, now that's such a good. So did you see? I actually only put the bandage around the palm. I didn't bring it up to the fingers. I like to leave the fingers completely loose, but if you, in the most of the protocols that we are following these days, the first week we'll be putting 3 fingers into here and she'll only be flexing that far anyway. So she's miles off. Then following week down to 2, following week down to 1, following week. So week 4 it'll be before you get anywhere near to that to holding it in the palm. But I know there are lots of people that talk about should you, to prevent flexion contractures, should you put a strap across the fingers? It's always worried me because you're exactly right. And that is that if you flex against it, that's an immediate resisted flexion and you could rupture. I think with good education, actually you can get away without putting any strapping over the fingers at all, just around the palm. Great question. Wonderful. Right, we're going to go messy.
Lovely.
Okay, we're going to start with messy. So, one of the ways, if you end up with a PIP joint flexion contracture, then one of the things that you can do, if you want to go the absolute true low prolonged stretch for the finger, tends to only don't respond to everything else. So normal night first, probably for a couple of months with that low prolonged stretch. But those ones that, I mean, I just in my practice, I tend to inherit people where things have gone wrong elsewhere, or it hasn't really quite done what you want. So I do see people quite late on. Same with central slip injuries, you know, if they just lose that ability, then this is a really nice method. So I am going to, this is what I always do with my patients as well, in order not to completely cover Rachel in plaster of Paris, tempting as it might be, I'm just going to pop this glove, help her pop this glove on, and the index finger is just poking out, which is what we want. Can we bring that down just very slightly there? There we are. Okay, so that just stops the rest of the fingers getting absolutely filthy. It makes it a bit easier. Right, here we've got some nice warm water. I will have to take myself to the sink afterwards just to clean up. So very brief introduction to the water. Then just rub down to get rid of the excess water. Now imagine that this joint is bent, because that's of course the reason that you are splinting it. You want to have done all of your heating and your moves and your passive stretches. I mean, you want to basically do your entire treatments first, and then you want to apply the plaster of Paris, and you ask the patient to actively extend as far as they can. What you don't want to do, as I've discovered bitterly by doing it wrong myself, is to actually put some force through. There's absolutely no need. All you're doing with this is holding them at their comfortable end of range. So again, just pretend you're a little bit bent. So we're going to wrap the plaster of Paris around the finger. How many layers? Just depends on the size of the finger, how strong it is. You can see I've actually cut the plaster of Paris into smaller strips, and so on and so on. Okay, now once you've put your layers on, you then, what you're going to do, smooth them all off and roll it back underneath. If I lift you up here, that's it, perfect. Roll it back underneath that PIP and a little bit there, so we get free movement of the MCP and the PIP. That works really well, like so. Okay, and then you ask the patient again to actively extend as far as they can. So you don't want to put pressure through it. I haven't put this on with force. It is literally sitting at its end of range, but it's sitting at its end of range for 24 hours a day. And that's what makes the difference. So I would then leave that to dry. It takes a good 15-20 minutes to fully dry off. Just make sure that you don't lose any feeling in the fingers. But if you haven't put that on with force, you shouldn't. If you haven't put force through, it shouldn't be a problem. How often do you change them? Well, I do them about once a week, and just slowly you just ask the patient to soak them off at home, or you cut them off when you get them into the clinic, and then you just place the next one. But every time you do it, make sure they get back their full flexion and work on their extension. Then when they've reached what you think is their maximum extension, you ask them to hold that position, and then you place this on again. Can you feel it getting a little bit tighter?
Yeah.
We might just let you take it off. So this is going to come off. That's the first thing. Now you can see if I do that, then the whole of the rest of the hand is actually still clean, which is remarkable. But actually, before that solidifies, I'm going to just pull that off.
Thanks very
That could
much.
be a bit of a disaster. Right, I'm going to get rid of all of this, and then we're going to. That's messy done.
Lovely.
Okay. Oh, sorry. Kicking you as well. Right. So, we've got a finger. Yeah, we've got a finger. So let's have a look at the volar little splint that we could do if you've got a hard end feel or a medium end feel and not a huge amount of change. Then what we're going to want to do is we're going to want to take a little bit of a pattern around your hand. There. If we put the camera, actually, I'm going to move you up to here. Sorry, this finger's. I'll bring you something to clean that in a second. Okay, so I'm going to draw around the middle finger. So I'm just assuming the problems with the middle finger, and just mark on the PRP and the DRP. I'm doing it in really big, thick pen so that you guys can all see it. So Rachel's just going to lift off there. And if I'm going to make just a little gutter, often need a little bit more at the level of the PRPs. Make sure that I come in around where the MCP is so that doesn't get in the way. And like so. Now I'm going to cut it out. Okay. And then I want to just try it on the finger, make any adjustments. So I can see that actually fits pretty well. I might want to take a tiny slither off both edges here. If I turn the hand this way up, so maybe just because you can see it's curling over. So just at this level here, I'm going to take a tiny bit off both sides. Okay. Now, you've got a choice. You could make that out of a very rigid material. Obviously, it's a tiny split, so you want it to be made out of a small material. So you could make it out of easy form, or you could make it out of polyflex. So I've got easy form to hand, so let's make it out of easy form. Either would be absolutely fine. So I'm going to dot it onto the material. I'm using a Sharpie, just again, so that you can see it. And I'm dotting, can you see, just on the outside of my pattern, which means that I can cut on the inside of my pattern and get rid of the marks without, without worrying about it, because I know it's the right shape and size. So pop that into the spin pan at the same time. I'm just going to give Rachel something. To clean her hand. easy form. So coming back to show you, again, I'm just going to cut on the very inside, nice long sweeps, so that we can get this to fit. And really, with the vast majority of people, this very is enough. So we just fit it like so. Of course, the PIP is bent. What I'll often do is just bottom it out underneath a little bit. So there's, as I put a strap on the top here, there's a little bit of space for it to work into. But remember, low load, prolonged stretch. So I'm not wanting to put huge force on. I just want to hold her at her comfortable end of range into extension. And I'm going to put a strap diagonal across the PIP. So it's going to wrap from here around and onto here. You shouldn't need one on the DIP. And if this splint is being worn at night time, you know, it's much more comfortable for a patient to add the extra length. If they're going to be wearing it in the day as well, I would probably make it just to DIP level so that you've got the sensate area of the finger available. So there's that little splint for you. Okay, brilliant. Get rid of that one. Now let's go to something a bit more complicated. So we were talking about the potential of having dynamic and static progressive splints. So again, imagine that we've got a PIP joint that is a little bit unhappy. Then I'm going to take a pattern and show you. I'm going to make a base that I could use either for making a dynamic splint or a static progressive splint, remembering that actually the base, it's identical. It doesn't matter which you're doing. Again, I'm just going to put this underneath. So again, if I move you up here again, Rachel, that's brilliant. We'll go middle finger again. So I'm going to draw around the hand. I'm doing it with this big thick pen just so that you can all see it. I was about to say at home. I expect most of you are at work. Like am I? This is my clinic. Okay, so I'm going to mark the PIPs, particularly the middle finger, because this is the one that I'm concerned about. I want to know where the MCPs are, and I want to know where the wrist is. Lovely. Lift up. Thank you. So I am going to make a little base because I have to block the MCP of the middle finger to be able to get a dynamic extension of the PIP joint. And the rest is really just making a base. So if I come around like this, this is going to give me the piece that I want. And actually, this is the only important bit. This is for stabilizing the splint. So let me cut that out and show you how that fits on Rachel. And then before we came on air, because I was just concerned that I wouldn't have enough time to do the detail. Okay, so remember, you can keep asking questions or have a chat or tell me if you do things differently or anything like that. It's fine. There are so many different ways. There's no right and no wrong. Okay, so this is how this would fit. So the MCP is flexion, which will help with the mechanical advantage. Material fits around a little bit better. That will sit into that position here, and it will secure it. Okay, so it's a real piece of work, isn't it? Here's one I made earlier scenario that I've already made. So this is going to sit over here. I'm blocking the MCP joint, and I've made a because that really works around the thumb to hold in position there. It's also, isn't it? It's really lovely. So here's this. See that? So it's just a strap on the front, very little. Imagine we've got a PIP that is flexed, and we've decided that a little volar splint isn't enough. We want to do a dynamic one. So what are we going to do to make an outrigger? So if I just swap this one for this splint onto the top to give, I'll show you now how I did that. So I'm moving over to the splint pan. Now I took a bit of the material that I was using and cut maybe 4 centimeters maybe in a length along like this. Heated it up, dried it off so that there's no water trapped in it, and then I rolled it. Now, as soon as you make a roll, it becomes really strong, because if you've got air in the middle, if you think about any piping becomes very, very strong because it's got a lot of contour and it will resist that. So that's all it was just a roll of that. And then I cut it, the one that I did, into two, so that I had one for each of those two splits. And the roll becomes floppy. It's not quite floppy enough. So to attach it, you really do need to use dry heat, not wet heat, because it's just not enough. It's not a good seal. So you can see I haven't put my strapping that I'm going to need at this part of the splint, because the first thing I need to do is to actually attach the outrigger piece that I'm going to put on. Now, there are so many different ways you can do outriggers, but this is what I, over the years, have come to rely on. I'm just going to I'm just heating the material enough that it gets tacky. And then I'm going, now it's really floppy. And now I'm just going to heat both ends. And now I'm putting dry heat to dry heat. And I've made a little outrigger. So then I'm going to pop it back onto Rachel's hand, thumb through the hole. Straps on there. Lovely. Just relax, relax. Okay. So now what I want to do is I now need to get this outrigger to exactly the right place. So if I think about the fact that there's going to be a cuff on the finger over the proximal phalanx, sitting here, with a pull. Now that pull has to be at 90 degrees. So I want to make sure that it's going to just depend, because if she's really flexed, 90 degrees is actually, if I turn it that way, see, if you're really flexed, 90 degrees is like out here. If it's the last, say, 30 degrees we're going to go for, then 90 degrees is going to be up here. So all I'm going to do now is I'm going to wiggle the outrigger into position over your finger, so that the center of this outrigger is sitting over the center of the middle phase at a 90-degree angle to this. And I'm going to punch hole in the material. Now, this is easier as the material is starting to go off. Here's my hole. So I want that. So imagine this is the contracture. I need to be right central over the finger, and I need to be 90 degrees above it. Now, when you make this yourself, it looks right, and then while you're faffing around, we're all faffing around all the time. While you're doing something else, what you discover is it's just moved a little bit. Don't worry, because if you discover, for example, that now the outrigger is not quite in the right place, now if I actually attach this through the hole that way, actually my 90 degrees is no longer to the hole, it's to the proximal lip of the outrigger, which gives me quite a lot of an angle. You can actually really, you can just pretend that that meant first. And it's the same actually on the other side. You can do it on the inner lip as well. Okay, so here is this. Now, how do we make a difference between what is a static splint and a dynamic splint? So, as I've said before, they are basically identical. The only difference is that you are using a static hold or pull for a static progressive splint, and you're using a dynamic.
Connection. Hopefully we should be back now. If anyone could just send something through the Q&A just so you can see us again. Or through the chat if anyone can see us.
Yes, thank you, Anna.
Perfect, lovely, thank you.
Hi, Jan. Nice to see you. So great, I can actually see the questions. Would I consider using the dynamic soft stretch finger splints? Basically, I used to use them a lot, and I almost never use them anymore. The reason is that we now understand that we want to go for low load prolonged stretch. So one of the things from talking to patients over and over again is that those Capener style splints tend to firstly have a really strong pull on them, and I know you can alter them, but secondly, they inhibit a lot of function, and thirdly, they get in the way, and fourthly, people tend to take them off. And what's really important with this is it's a prolonged stretch. So you really want people to wear their splint over a long period of time. Nighttime is best, ultimately. And because it's a circumferential splint, I always worry a little bit at nighttime because I don't want it to cut off the blood supply or to, you know, cause any sort of neural compression. So there is a place for them, but I tend not to. And because we know that to get the changes in the tissue that you really want, you need to have at least 6 hours in a row. 6 hours in a row, not just 6 hours out of every 24. It needs to be in a row. Then we also know that very few people are going to manage to wear those splints for 6 hours in a row. Let me just show you what I've done here. So this would be a static progressive splint. Now, this has got a little strap. I don't know what I did with the little strap. I don't know where it went, but let's just make you another one because you need a little strap to stabilize around the PIP. So once I put the outrigger on, then I added a little bit of Velcro over the top of it, like so. And then we've got the outrigger here, and I actually attached it at the bottom. So I don't know if you can see. What I did here was I actually attached a little hook. So these are like, where are they? Here. Almost like a little bra hook. And I opened out the little hook bit to just leave the loop. And I attached it onto the splint. So I've now got something for this to run through. So it stays low profile. So it's not in the way for the patient. So that would be a static progressive splint. Now, if I take that off, I've still got my monofilament here, so it's still going to pull. If I pull here, it's still going to pull back. But if instead I replace the solid monofilament with, in fact, some elastic, then all of a sudden this has become a dynamic splint. So I'm just going to put a little knot if I've left myself enough. If I haven't, I'll put another one. So all fingers, thumbs. So what I actually normally do is use just the cuffs that are not connected to all of this. If we put this on to Rachel. It's really long. Place it through, depending on which angle, so get the right angle. You come through here. Okay, and now I'm going to put myself a little knot. So I've got some traction. Slightly thicker monofilament than the monofilament I'm used to using. There we go. Right, so now I've got a little loop here. And I'm going to attach instead some elastic. So now if I put elastic, can you see, you might see, I'll show you that in a minute. I just literally rolled a bit of the material up and put a hole through it. Super simple, so you don't have to add anything. And if I pop that through, I've now got a dynamic splint. Again, they look pretty much identical, but now I've got an elastic traction that is going to constantly pull. This is too far up now. It needed to be through the hole properly, okay? It's going to pull on that finger and make it adapt. So if you've got somebody wearing this for 6 hours, it will adapt as it goes along. Hopefully that makes sense. So I would actually want to put it up and through this hole. That hole is now in the right place for the finger. These are a bit tight on you, these ones, aren't they?
They feel quite nice though. It's a
they?
nice soft material.
Oh, it's
yeah.
suede. They're lovely. Yeah, they really do feel nice. So I'll put that through there. Now that's sitting in a much better 90-degree angle, and I put that in. Now there is another alternative, which is even easier and doesn't need these adaptations over the back of the splint. And I could, taking this off, just get rid of the monofilament on here altogether and just go elastic through the whole finger here and literally just go straight up here with the elastic. Now, if I was going to do that, I probably would need the outrigger to be a little bit higher because otherwise I haven't got enough. I mean, there's just not enough space. But imagine the finger were down here. Now I've got the space for that to be a direct dynamic pull onto the finger. And then you don't need anything here. But of course, if you do put something there, then it's going to be an even better dynamic pull. Put that through there, run that through here, run that down through the hole at the bottom. Now I've got much more elastic, which gives a better dynamic pull. But it's really important if you do that, you make this low profile. You can see it just doesn't stick up at all. Otherwise, people are going to get it stuck all the time. Okay. So those were the complicated splints. Okay, let's pop that off completely.
Yeah,
All right.
yeah.
Grand.
Thank you.
So let's just to finish off, we're keeping an eye as well to make sure that I am watching the time. So last but not least, what we're going to do is, I'm just going to put that underneath it again, so we don't draw anything. Now this time we'll just do it with the big camera because it's a big splint. Let's go backwards to what are you going to do with those zone 5s that are, everything is really tight. And ultimately you're going to make action, oh, that was stupid, wasn't it? Let's try again. This is just to show you all guys, it's live, right? So leave the thumb out. I don't really want the thumb involved unless it was a thumb split. We haven't really talked about thumbs today, have we? Probably want to come this far on the forearm, lovely. So I'm going to make a splint. Always, I always, even 30 something years later, I am always making patterns. Now, you have to think that when I had Rachel's hand flat on the table, her wrist was at neutral and her fingers were extended. But what we want is for the wrist to be extended and the fingers extended. So I actually need to make this splint significantly longer than the fingers because they're going to open out in length. Try all this. Again, with the hand end, to get that nice rigidity, I'm going to make sure that I've got flat under the fingers with little rims, little ridges. Okay, so here we have this hand. So imagine we're all tethered in here. And when I try and extend her wrist on its own, it's not bad, and when I want to extend the fingers out on their own, it's not bad, but when I try and add them together, it's super tight. So I'm going to make a splint that is going to cover then around 50 to 55% of the circumference, and then onto here, and I want to make sure there's enough material so that when I get her into that end of range, I don't end up having to make another splint. So can you see that actually her fingers are right at the tip there when I do that? So that is actually, so if we're here, it looks like that's ever so long, but as soon as we start adding that extra length, it's going to go. Right, so let's just cut that out. Now this time I've got easy form. One of the reasons that I've chosen easy form is because it's a very large piece of material and you want something that's going to really not lengthen on you as you pick it in and out of the splint pan, utterly reliable, and you can alter it many times. You can serial splint with this 8, 9, 10 times and it will have no effect on the integrity of the material, which is fab. Now, I apologize for the noise. Any more questions?
Not at the moment. We had a couple of comments here. We had not so good connection, but no questions yet.
Now, I've actually got easy form 2.4 here rather than the 3.2. Again, if I can get away with having a slightly lighter material, slightly thinner material, it's nicer for the patient. Pop that into the splint pan, rid of that. And while that's in, I'm just going to prep my straps. So I know I'm going to want to have a strap at the proximal end and a strap at the wrist, and then something to stop the fingers from popping up, because that's what they're going to want to do. They're going to want to curl, because if you're short and tight, then everything is going to want to curl. So while that splinting material is in, I'm just prepping the straps, always curve the edges, it'll stay on so much better.
While Nicola's doing that, we've only got about 5 minutes left in the call. So really, if anyone does have any questions, please put them into the chat. If we don't get a chance to answer them here, we'll send a copy of them to Nicola to come back to you direct. So please do send through any questions that you have.
And don't forget, no questions are silly question, right? No questions are silly question. Okay. So if I had a more floppy material, I'd have to be super careful with this amount of material. But easy form is just, well, it's easy. It's easy. The clue's in the name. The clue's in the name. Okay. Big long sweeps, because I don't want to have bits of splinty material that are slightly sharp on the edges. Because I like using smaller scissors. The blades, of course, are slightly shorter. Really important, long sweeps. Okay. That in very quickly. Okay, you ready?
Yep.
Now, this is a big split for you to manage on your own. So if you're worried about managing it on your own, start in supination. Because if you start in supination, then you've got things, you've got gravity working with you. But I'm not worried. Brave. Right. Okay. So that's my cutaway for the hand. So I'm just going to get this bit right. I've got lots of working time, even though this is 2.4. So I'm just going to place this strap on here and a nice wide strap at the base. And while the material is just cooling, I'm going to I'm not doing up tight. It's really loose. Okay. Roll this to give it a little bit of extra integrity. Going to have a nice strap at the wrist. Trying to get this done for you before it hits that 2 o'clock. Again, nice and soft. Don't do it too tight. I'll just adjust those after. Now I don't need to worry about this bit, and I can concentrate on what's going up here. So I'm going to put a little ridge. I know you can't see it too well here. I might just take it off to show it to you in a second. But I can see that I want my straps, and I'm doing this while it's still warm, because then they will fit really well and they will stick really well. One's going there. One is going there. So you can see that they're, oh, I shouldn't have chosen white and white, should I? That was a bit silly. Sorry. I just had the material they gave me. Let's pop this off. And then I'm just going to grab some some strapping material. So I'm just going to take a narrower one for the fingers. It's going to come around onto here. Did we get any more questions?
So the other one question we've got is, do you have a preference, Manchester short or full forearm?
No, I don't have a preference. And the reason I don't have a preference is because I almost never see flexor tendon injuries myself right from the start. So I'm generally seeing people who've had flexor tendon injuries later on when things haven't gone quite so well, and they've come to find me for an opinion. So it's actually quite rare, because essentially, of course, they're managed in the NHS. It's quite rare for me to actually see a primary flexor. So I don't have enough experience myself. I teach both, and certainly on the NES courses we teach both the traditional early active movement with the traditional full length hood, and we teach the Manchester short. And let me just show you this, if I can. Sorry to put you in a
No, no,
awkward space. So I've gone from mid position of the wrist now, mid with the fingers extended. And can you see I've just lined this strap so that she's got some pressure on the PIPs, and there is plenty of length left here for me when I add more length here. In fact, as I do that now, I'll do that with you sitting there. You can see that the fingers creep right to the end of the splint. So I've left enough length that as I push on through, the fingers are the right length. Right, I think it is pretty much 2 o'clock. So it's been lovely to be with you, and hopefully it's felt a little bit more interactive this time. It's really lovely having questions as we went along. Look forward to the next webinar. Take care.